Okay, hello everyone. It is 12:01, so we will get started. Thank you for joining us today. And on behalf of Dr. Amin Yazdani, who is the Director of the Canadian Institute for Safety, Wellness and Performance, I'd like to welcome you to today's webinar, which is the first of our paramedic series that will address the mental health among Canadian paramedics during infectious public health crises. My name is Corey Jameson, and I am the Public Relations Intern at the Canadian Institute for Safety, Wellness and Performance, which is hosted at Conestoga College's School of Business. Frontline healthcare workers, such as paramedics, have risen to the challenges that COVID-19 has presented, playing a vital role in maintaining public health and safety in the face of the health crisis. Paramedics, however, are at a high risk for developing mental health injuries due to a unique set of stressors. Paramedic service organizations have expressed their concerns that the COVID-19 pandemic will be an additional significant stressor for their frontline staff, further increasing the prevalence and severity of mental health injuries. This research project aims to rapidly mobilize solutions and expertise to develop a rapid guideline for the paramedic community to prevent and manage mental health injuries during and after the COVID-19 pandemic. The guideline will also be a great tool for the paramedic community to prepare for future public health crises. Our speaker for today is Bronson Du. Bronson is a research scientist at the Canadian Institute for Safety, Wellness and Performance. He has expertise in developing organizational level guidelines and resources for the prevention and management of work disability, and in integrating human factors and ergonomic principles into industry-specific design standards. He applies a systems approach for data collection, analysis, interpretation, and reporting to inform the development of workplace interventions. The format for today's webinar will be a presentation from Bronson, and then we will have time for a Q&A session. If you have any questions during or after the presentation, please use the Q&A function of the Zoom platform to ask any questions you may have, and then we will get to answering them near the end of this webinar. I will now hand it over to Bronson to begin his presentation.
Great. Thanks for the introduction, Corey, and good afternoon, everyone. I'm very delighted to be here today to share some of the research and development that we've been doing here at CISWP to support paramedic service organizations in addressing operational stress injuries. Now, over the past 5 years, our research team has been working closely with the Canadian paramedic community on various projects to support paramedic services in improving performance, health, safety, and well-being. And last year, CISWP was awarded funding from the Canadian Social Sciences and Humanities Research Council on behalf of the College and Community Innovation Program, applied research for rapid response to COVID-19. So we were funded to develop a guideline for addressing the mental health impacts of COVID-19 amongst Canadian paramedics. And so in this series of 4 webinars, I'll be discussing some of the research and development that's gone into creating the guideline. That's going to be the first 2 webinars. In the third, we'll reveal and introduce the new guideline. And in the last webinar, we'll go over some specific case examples of how recommendations within the guideline have been implemented in workplaces. And then we'll talk about the next steps to ensure that our conversations about addressing mental health doesn't fade away once the pandemic is over. All right, so in today's webinar, my overall objective is to present the foundational research and framework for the guideline and present an overview of findings from our systematic review of the literature. On the agenda today, well, I've broken this presentation up into two sections. So we'll start off with some background information about paramedic work and the importance of addressing OSI in the workplace as part of background. And also, I'll talk a little bit about the foundational research for this guideline that was completed before the onset of COVID-19. In the second part of the webinar, I'll provide an overview of the scientific literature available on the mental health of paramedics during infectious disease outbreaks. So let's begin with background information. All right, so roles of paramedics. Paramedics work at the intersection of emergency response and healthcare. So they're similar to firefighters and police in that they respond to 911 calls in the community, but they're also similar to nurses and doctors in healthcare, providing medical care to patients. Now, very, very generally, paramedics provide out-of-hospital emergency medical care, but they also do preventative calls as well, such as community paramedicine. And right now, paramedics play a large role in providing vaccinations in the community. Now, inherent to the work is tending to medical calls. And some of them can be exciting and manageable, while others can be frustratingly non-urgent or strenuous and psychologically traumatic. Other characteristics of the work is that it often involves long hours, shift work, being on call, and overall the work is considered to be high stress with little job autonomy. But the job can also be very fulfilling. Unfortunately, paramedics are a high-risk occupational group for a range of mental health problems, including both clinically and non-clinically diagnosable conditions that interfere with daily functioning. And so for this presentation, we're going to refer to this range of mental health conditions using the broad term operational stress injuries, or OSI. As mentioned, paramedics are a high-risk occupational group for OSI, and presented in this table are two studies. The one on the left column is a Canada-wide national survey of public safety personnel's mental disorder symptoms among a bunch of other factors that were measured. And on the column, I've extracted only the paramedic data. And the data presented in the right column is based on a meta-analysis on the prevalence of PTSD and common mental disorders amongst ambulance personnel worldwide. And overall, these numbers are about 2 to 3 times higher than the general population. And I just wanted to point out that among the Canadian paramedics, there's an alarming 49% who screen positive for at least one mental disorder. And again, with the ongoing pandemic, it's been presumed that this number is only going to increase. And these occupational stress injuries, operational stress injuries, not only are devastating to the individuals dealing with it, but also for their communities, friends, families, coworkers, their work capacity, and the organization's ability to provide responsive and quality paramedic services. So this brings up the question, what can be done to reduce the risk and impacts of OSI? We know that responding to potentially psychologically traumatic events are a part of paramedic work, and that's unavoidable. But there's also increasing evidence that suggests organizational factors such as psychosocial safety climate, leadership style, and mental health training and awareness, these organizational factors to be significantly and independently associated with OSI. So this is important because recognition that of these modifiable organizational factors offer paramedic service organizations an opportunity to implement organizational level strategies to manage the risk of these injuries in their workplace. Now, according to one study from the Canadian-wide Survey of Public Safety Personnel, organizational and operational workplace stress might even play a larger role on public safety personnel's mental health than potentially psychologically traumatic events. And that's been the goal of our research, to develop tools such as guidelines to support paramedic services in addressing OSI in the workplace. So in other words, our research really focuses on what paramedic service organizations can do, and less so on what individual paramedics can do for their mental health, or what types of clinical treatments that mental health professionals can provide for paramedics. And before we get into the studies, I want to talk a little bit about this disease prevention model for intervention, because this model has been used by many resources to help organizations address various states of health along a continuum. And so here on the screen, you see our adapted version of this model. So at its core, the model features 3 levels of interventions: primary prevention, early detection and intervention, and disability management. So primary prevention initiatives, these are aimed to help maintain good health amongst individuals at all stages along the health continuum, with a main focus on the healthy individuals. Early detection and intervention initiatives, those aim to identify and support individuals with early signs and symptoms of a disease and injury. And disability management, these would be approaches aimed to support those recovering from a work debilitating illness or injury, and if or when the injury or illness becomes more manageable, it's their work reintegration. And so the need to use this type of model as a multidimensional approach for stress management amongst first responders has been proposed in the literature. And so we've adopted this disease prevention model as a framework for the first 2 studies that I'm going to talk about. So we'll start with one of the studies was an environmental scan, and our objective here was to identify recommended organizational programs and practices for each stage of the disease prevention model for intervention. And so we obtained resources through a web-based search and snowballing techniques. Through the search, we identified 5 paramedic-specific documents. There was an ombudsman report of the Toronto EMS back in 2015, when it was still called Toronto EMS. There was also the Canadian Paramedic Health and Wellness Project. We also found the CSA Z1003 Psychological Health and Safety for Paramedic Service Organizations. There was a briefing from Paramedics Chiefs of Canada on OSI. And then there was a guide from the States for building an effective EMS wellness and resilience program. So since these publicly funded resources for addressing PTSI amongst paramedics were limited, we also supplemented our search results with resources that went beyond the scope of paramedic work. And we even included general resources for employers. So these additional search results were not exhaustive, but were used as supplemental material. So that's just what we did for the environmental scan. Along with that, we conducted interviews to explore key informants' perspectives on the existing and desired organizational-wide initiatives for, as well as the challenges and potential solutions to the primary prevention, early detection and intervention, and disability management of PTSI in Canadian paramedic service organizations. And so we conducted semi-structured interviews with paramedics, organizational leaders, and union representatives. And the interview guide was designed to incorporate discussions surrounding the 3 levels of intervention. Interviews range from 68 to 148 minutes, averaging just over an hour and a half. And all the interviews were audio recorded, transcribed, and analyzed using thematic analysis. All right, so let's get to some of the data for both of the studies. Here's a very, very high level summary of what we came up with from the 2 projects. The left side shows 8 desired organizational elements that were identified through the interviews. And on the right are the organizational initiatives identified through the environmental scan. So I know there's a lot here. I'll just go over a brief overview of each stage based on the disease prevention model. Starting with primary prevention. So when asked about organizational initiatives or elements for primary prevention, our interviewees consistently suggested their desire for a psychologically healthy and safe work culture, which included things like taking reports of OSI seriously and recognizing that OSI was a legitimate injury. It was also very clear that this element, having a psychologically healthy and safe work culture, that this was an overarching theme that both impacted and was impacted by all of the other elements and initiatives that we're going to talk about. Our interviewees also desired consistent supervisor support, often comparing good versus bad, old school, or disconnected supervisors. They also stressed the importance of mental health training and awareness in reducing stigma and creating a shared understanding of OSI. But they also reinforce that mental health training needs to be coupled with opportunities to recover and maintain resiliency. So really having opportunities to apply some of the knowledge that they learned in the training. But they also identified that there were many organizational barriers that prevented its application, including things like shift work, the on-call nature of the work, and limited rest breaks in high volume areas, and staffing shortages. So from our interviewees, these were 4 elements that consistently came up for primary prevention. Now, from the environmental scan, we also identified some programs and initiatives. We found stigma reduction programs, having a policy statement, wellness checks, health promotion programs, and mental health training as well. So for each of these initiatives, we actually extracted the value of the programs, the best practices or recommended practices for the programs, some examples of its implementation in workplaces, barriers to implementation, as well as any additional information that we should take note of. Now for initiatives for early detection and intervention, again, these are aimed to identify and support individuals with early signs and symptoms of a disease and injury. And this is important in the context of OSI because we know that they can be reversible and temporary with early intervention. And so when we asked our interviewees about what's ideal for early detection and intervention, they said that there needs to be mechanisms to recognize the diverse signs, symptoms, and stressors of various operational stress injuries. So not just only focusing on PTSD or not just recognizing the critical calls, but to also recognize the cumulative and the less traumatic stressors as well. In addition, they also stressed the need for a variety of support initiatives to accommodate for individual differences. And so from the environmental scan, we also identified numerous initiatives to support early detection and intervention. And again, these recommended practices for each of these initiatives were documented in the environmental scan. And lastly is disability management. So for disability management, interviewees consistently suggested the need for communication during medical leave. And this was another one of those really difficult elements to achieve because, well, these communications needed to be built upon a good trusting relationship between workers and employers. And this isn't necessarily always established prior. Another element was having meaningful work accommodations. And for paramedics who were ready to be reintegrated back into the front lines, there were many pre-established options for gradually returning to full shifts. But for paramedics who were not yet able or unable to return to the front lines, finding meaningful work has not always been so straightforward. And readily available alternative duties were often administrative tasks, which many paramedics did not find meaningful. Now, from the environmental scan, we see that disability management was more of a coordinated process as opposed to an individual intervention. And so we identified recommended practices for each phase of the process. All right, so that was a very brief summary of the two foundational pieces of work that would lay the groundwork for the guideline. And even though it's not directly related to infectious public health crises or infectious disease outbreaks, there's a lot of transferable components here. And I think it's important to show you the approach that we've taken in creating the framework for the guideline. Both the reports for these projects are available on CISWP's website, and the interview study about the desired organizational elements for addressing OSI have recently been accepted for scientific publication in a journal called Work. All right, so that's the end of the first part of the presentation. Now we're going to get into the scientific literature on the mental health of paramedics during infectious disease outbreaks. So last year around this time, we were awarded funding to develop this guideline. And one of the first things that we did was a scoping review to systematically review the literature that's related to the mental health of paramedics during infectious disease outbreaks. And we did this because, well, if we're going to develop something that's evidence informed, we needed to know what is the evidence and research available on this topic area. Specifically, we wanted to know what were some of the potential occupational stressors associated with OSI amongst working paramedics during infectious disease outbreaks. We also wanted to identify any potential organizational mitigation strategies to reduce the risks and the impacts of OSI amongst paramedics during these times. And so we searched 3 databases for articles that contained all 3 of the following concepts: mental health, paramedics, and infectious disease outbreaks. For each of these concepts, we developed a list of similar and relevant terms and subject headings for each of the search databases. So with the search, we found 644 articles, and we further screened them to ensure that they were relevant for inclusion in our review. I'm not gonna go through the whole primary and secondary screening process, but in the end, we had a final sample of 27 articles. And this sample of papers were unique in that they were all peer-reviewed, original articles that discussed the occupational stressors and organizational level mitigation strategies that might impact mental health of paramedics during infectious disease outbreaks. We also only included articles that were written in English. And that's just due to the capacity of our our researchers to only use English. I should also note though, following the stepped response for psychological intervention, we included articles that discussed stressors or mitigation strategies related to the basic needs and resources, information, and support and psychological first aid for paramedics. And from all of the retained articles, we extracted general information such as authors, publication year, study location, type of disease outbreak, study population, and sample size. We also extracted study characteristics. So those were things like study design, the research objectives, any factors that were measured, and the principal results. And of course, we extracted occupational stressors and organizational mitigation strategies that were identified in the articles. For today's webinar, I'll provide an overview of the literature that's available based on the main topic areas of the articles. So in our sample, there were 5 main topic areas: mental health, duty, so that's willingness to report for duty, training, preparedness, that's pandemic specific preparedness, and vaccination for the pandemic disease. And there was one other article that talked about ambulance ventilations for the rear compartment. All right, so let's start with mental health. There were 3 studies that were sorted into mental health. 2 of them surveyed paramedics' perceptions of fear and anxiety towards responding to pandemic conditions. And one of them described and presented the implementation of an intervention to support mental resiliency. So among the surveys, one of them asked paramedics to rate their perceived fear and unfamiliarity for 40 different types of disasters. So those were things like landslides, nuclear reactor accidents, terrorist events, and outbreaks of new infectious diseases were actually rated as one of the highest for both fear and unfamiliarity. Similarly, 89% were very anxious, and 89% were very anxious, and 85% perceived high personal risk associated with working under pandemic conditions. Now, there was one really interesting mental health specific intervention that I want to highlight, and that was one that was written about by Schreiber and colleagues. So they described the implementation of the anticipate, plan, and deter responder risk and resilience model. So in brief, this intervention consists of 3 components: anticipate, plan, and deter. So in the anticipate phase, it really focuses on preparing workers on the unique stressors that they'll be exposed to during a crisis, and what were their expected responses, such as sleep disturbances, fear, anxiety, grief, anger, and such. Now, the second phase was plan. So this involved developing a personal resilience plan. And so this plan asked the workers to reflect on and identify their expected stress reactions, what they would perceive to be the most stressful aspects of responding during an infectious disease outbreak, their social support systems, their positive coping strategies, and their career motivation. And lastly is deter, which involves using a mobile app to self-monitor exposures to operational stressors for timely initiation of their personal resilience plan. And so the way this app works is that at the end of each shift, the worker would log in whether they had been exposed to any of 19 evidence-informed traumatic stress risk factors for PTSD. And so this app tracks the worker's exposures to both the traumatic and cumulative stress and then it'll provide suggestions to the worker as to when they should initiate their personal resilience plan. But what I thought was really interesting about this app too was that all the aggregated data and the de-identified data can be made available to organizational leaders in real time. And so this information has actually allowed organizational leaders to gain a better understanding of what were the stressful exposures amongst their workforce in real time, and then develop targeted mitigation strategies to address those. So I thought that was really cool. All right, so next was training. Now, instead of mental health training, the 4 articles that were sorted into training assessed paramedics' knowledge, skills, and abilities related to infection prevention and control. And there were a couple of the studies that actually evaluated the effectiveness of some of these training programs. So in the articles that assess the extent of pandemic-related knowledge, Lee and colleagues found that 70% of EMS leaders and frontline workers received training for highly infectious diseases. And almost 2/3 reported that annual retraining and continuing education was mandatory. And almost 85% of respondents were able to correctly identify the routes of exposure for several highly infectious diseases. So now if you flip the findings, we can see that there's about 30% of workers who have not received training, and that about 15% were unable to identify the routes of exposures for highly infectious diseases. And now with the evaluation of infection prevention and control programs, there was one intervention, a 30-minute pandemic preparedness training intervention. So this one consisted of a standardized lecture, demonstration sessions, and hands-on training to correctly don, doff, and check the fit of respirators. This intervention, 30-minute intervention, significantly increased workers' intentions to use PPE, receive vaccines, and it also increased their willingness to report for duty during a pandemic. So this was one of the more successful interventions that we found. There was another study that looked at standardized patient scenarios to help with identifying potentially infected patients and the proper donning and doffing of PPE. And so this study showed some promising results, but there were no statistical analysis done due to its low sample size. We found 3 articles about vaccination for pandemic disease, and they were all related to the pandemic influenza in 2009. So generally, these articles study the rates and the positive and negative predictors for acceptance for pandemic influenza vaccine, and then comparing them to seasonal influenza vaccination rates. And so in that table, we can see that pandemic influenza vaccination rates among paramedics range from 55% to 68.5%. What was noteworthy here, though, is that the numbers from the fire department of NYC, New York City, so that this is a fire/EMS department, and they actually implemented an organizational-wide free and on-site vaccination program for the pandemic vaccine. And they found that there was a much higher acceptance rate when vaccines were offered through the campaign compared to when vaccines were offered through regularly scheduled medical checkups. So there's a lot of success in the vaccination campaign. And it was believed that it was due to the targeted education and some like social pressures to get the vaccine as well. All right, and duty. Now, depending on the scenario, willingness to report for duty ranged from 4% if no vaccine or PPE was available, to 97% if an antiviral medication was guaranteed after unprotected exposure to an ill patient. Now, this is a huge range. So it's important to note that these were surveys conducted under hypothetical scenarios that was aimed to identify predictors and barriers to willingness to work. But the actual numbers of, say, work refusals or role abandonment would probably be quite different in reality, as we have seen in the current existing pandemic. But in terms of the predictors and the barriers to willingness to work, I'll go into that in a later slide. When it comes to who comes first during outbreaks, this was a question asked in one of the studies. They found that 45% said that work obligation comes first, 29% said family safety comes first, and a quarter said personal safety came first. And so from this data, we see that paramedics are a very altruistic population, and we see that in the data, right? But we also see that there are some limitations to this sense of duty and professional obligation, meaning that the willingness to work is not infinite. And so there were a couple studies out of Australia that looked at what were considered to be some acceptable limitations to duty during pandemics and other disasters. And based on their focus groups and interviews with the paramedics and community members, they found that acceptable limitations to paramedics' duty to treat during disasters, including pandemics, should be based on paramedics' physical health, mental health, and competing personal obligations. And from the study, they also noted that, all the interviewees noted that while paramedics have an individual degree of obligation to respond during a pandemic, paramedic service organizations have a much higher level of obligation to protect the health and well-being of the workforce. And this really goes back to what we're aiming to do with our research and with our guideline to support paramedics in protecting the health and well-being of their workforce. All right, and this is the last category, preparedness, pandemic preparedness. There were two main groups of papers that were grouped into pandemic preparedness. The first group evaluated organizational preparedness. So one study found that most EMS agencies that they sampled did not actually have broad formal plans for response to large-scale pandemic events. And the few organizations that did have plans relied heavily on mutual aid from agencies that might not actually be able to provide aid during a crisis. Another study benchmarked the emergency response plans of EMS agencies against the Center for Disease Control's EMS checklist for Ebola preparedness. And I've on the screen, I've just provided one section as an example of what this checklist looked like. And they found that organizations met 36 to 85% of the checklist. And lastly, there was a study that reported a multi-agency pandemic simulation exercise, which included a lot of different agencies: fire, law enforcement, pre-hospital care providers, first receivers, the local emergency management agencies. And through this simulation exercise, they uncovered gaps and challenges to the pandemic response. And these gaps mainly revolved around communication and coordination between agencies. And this really supported the need for an incident command system. There were also articles that described organizations' experiences and lessons learned in responding to infectious disease outbreaks. And so generally, these articles discuss changes to the infection prevention and control protocols, quarantine protocols, training, scarce resource allocation, and altered standards of response, such as using designated trucks for patients with probable suspected or confirmed cases. All right, so that's a quick overview of the main topic areas. With all the data that we found in these articles, we also created a conceptual map of how all the various factors studied are related. So there were research articles that performed inferential statistics, and with that, we identified and mapped out all of the significant relationships. And so for all of the factors, we deductively sorted them into one of 5 main categories and color coded it. So I'll just quickly get you orientated. In the green boxes, these green boxes represent organizational interventions. So we found 4 of these. There was the 30-minute training program that I mentioned earlier for pandemic preparedness. There was a mandatory vaccination policy, and this was out of the States. There was also the vaccination campaign out of the Fire Department of New York City that we mentioned. And there was an ambulance ventilation system that increased air exchange rate. Now, in the blue boxes, these represents behaviors and behavioral intentions. And these included willingness to work in another community, willingness to wear PPE, previous vaccination status or seasonal vaccination acceptance, and pandemic vaccine acceptance. So in general, we can see that these were all favorable behavioral or behavioral intentions during an infectious disease outbreak. In the red diamonds are organizational outcomes, and there were really only 2. Airborne particle concentration was found to decrease with increased air exchange rate. There was also sick days. So this outcome was based on the fact that the percentage of people who needed 1 or more sick days due to a diagnosed respiratory condition, this rate was lower amongst workers who accepted the pandemic vaccine compared to those who didn't. And the light blue boxes represents knowledge. So this is actual knowledge that was assessed via like a quiz in the survey. And this is different from having a sense of knowledge or sense of competence. So this represents actual knowledge. And then in the white boxes with all the different colored outlines, these represents attitudes, beliefs, and feelings, which were further categorized. So the purple outlines represent sense of competence. So that would be things like confidence in knowledge and ability to work safely. The orange-ish brown one represents sense of family safety. The yellow one represents sense of obligation. The green is sense of personal safety. The magenta represents sense of seriousness. So an example of that might be perceiving that the pandemic is a serious disease and could have negative effects such as death. And then there were the red boxes represents emotions. So there were 2 measured. It was anxiety and overall concern. Okay, so now that we're a little bit orientated with this map, I'll go through one example for willingness to work. As I said, I would do that earlier. And so right off the bat, you can see that there's only one study of the training intervention that found significant increases to willingness to work. And that's indicated by the green box in the top left corner. Now, if I could direct your attention to the light blue boxes for knowledge, you can see that there's no direct link between actual knowledge and willingness to work. In fact, knowledge of the pandemic influenza was shown to be associated with increased perception that the responder's partner would have a high degree of concern related to quarantine. And that's actually negatively associated with willingness to work. And looking at all of the white boxes with the colored outlines, we also see that willingness to work is associated with a lot of factors related to attitudes, beliefs, and feelings. So for example, being confident in the knowledge and ability to work safely, perceiving adequate knowledge about the impact of the pandemic on public health, and having received prophylaxis and so on. But we also found some negative predictors, and that's indicated by the little negative sign in front of the reference IDs or in front of the numbers. And those were things like overall concern for family, and perceived partner to have a high degree of concern. All right, so just to summarize some main takeaways from this map, there's a lot you can look into here, but some main takeaways were that there were only 4 organizational interventions that I identified in our review that have shown significant results. The map also indicates that there are several factors related to attitudes, beliefs, and feelings on the entire right column that there are significant predictors for these favorable behaviors or behavioral intentions during an infectious disease outbreak. However, many of these factors have not been measured in program evaluation studies, or they may not have been a focus in the development of interventions. So this is especially important for the development of training programs, because traditionally it's been about transferring knowledge. It's been knowledge and cognitive based, which is very important. But these findings suggest that an emotional and affective component should also be integrated into the programs, such as building confidence in workers' knowledge and abilities to work safely, and helping them recognize the importance of their role in a pandemic response. All right, so I think we covered quite a bit today. We also extracted stressors identified in the literature. I'm not going to get into this today, but it's just going to be a little teaser. But I thought, it would be interesting that for next webinar, we compare our findings of the occupational stressors in the literature with what paramedics and organizational leaders have told us during our interviews with them at the earlier stages of COVID-19. So that's going to be for next webinar. We also extracted a bunch of organizational mitigation strategies that was organized as much as possible based on the organizational elements that we identified in the studies from part 1. And through this lit review, we also found some additional themes or categories as well that included communication, emergency preparedness, and infection prevention and control. So next time we'll also compare what type of mitigation strategies organizational leaders have identified to us through our interviews compared with what's been identified with the literature. So I'm really excited to give that talk and working hard to get those slides together. That's going to be for next one. And so from this webinar today, I hope you have a better sense of the research and the approach that we have taken to develop the guideline and the research and evidence that's available on this topic area. So I'll leave you with one takeaway, and that's there's no silver bullet for addressing operational stress injuries in the workplace. An ongoing, comprehensive, and coordinated approach is needed. So that's the end of my prepared presentation. At this moment, I'd like to thank our funding sources, DRDC, Defense Research and Development, for the projects that were completed prior to COVID-19. And I'd also like to thank CIRC on behalf of the College and Community Innovation Program, Applied Research Rapid Response to COVID-19 for funding the research and development of this guideline. Would also like to thank my research team, Dr. Amin Yazdani, Dr. Marcus Young, Dr. Philip Bigelow, Dr. Veronique Boscart, and Dr. Bedin Nauruzi Kia. Also like to thank our research assistants, Sarah and Jenny. And of course, we'd like to thank our research partners, PSHSA, PAC, PCC, County of Renfrew, PO Paramedics, and AHS, Alberta Health Services. And of course, mostly we'd like to thank our participants who volunteered for all of the studies. So thank you. I'll turn it over to Corey now for moderating the Q&A.
Okay, thank you, Bronson, for such a great presentation. And thank you to those of you who submitted questions for the speaker. If you do still have questions, please use the Q&A function. We just have about 10 minutes left of the webinar, so we'll begin the Q&A session now. So we do have our first question asked, what is the main scope of the guideline that's under development? And also asked, when will it be released and how can it be used to prepare for future possible public health crises?
That's a loaded question. That's a great question. So this guideline is based on some of the key elements that we found in our research. So based on those 8 elements, plus some that are going to be specific for pandemic infectious disease outbreaks. And the intention of this guideline is tailored towards what can the paramedic service organization do to help to kind of create a psychologically safe and healthy work culture. And it goes through a bunch of elements. So some might be how to goes through developing a policy statement for OSI, how to plan and ensure that there's adequate PPE, how to ensure that there's communication, effective communication towards the workers. So things like really communicating how were paramedics' mental health and physical health considered in the decision-making process and things like that. So it's a guideline that's tailored to organizational leaders, and we hope to get that ready for mid-August. In terms of how to ensure that it's to prepare for future pandemics or infectious disease outbreaks, we do plan on also creating a supplemental piece where it's kind of like an audit and self-reflection tool where we go through a checklist of all the components that we recommend in the guideline. And it's kind of a reflective piece for organizations to say, hey, this is what we did for this pandemic. How can we improve and fulfill more of this guideline for the next pandemic? So I hope that answers your question.
Perfect, thank you. And just to elaborate on when the guideline will be available, is there a specific date someone was asking or a specific timeline, and will it be free?
Yeah, so specifically we're hoping for August 16th of next month. That's going to be for our 3rd webinar. And yes, it's going to be free.
Okay, perfect. Thank you for answering those questions just in the last 5 minutes of the webinar. I will just bring your attention to our upcoming webinar schedule. So here we have it. I do want to mention the one date that has been changed just because of the holiday that's coming up. The date on August 2nd for the 2nd webinar of this series will be changed to August 3rd instead. So feel free to take a screenshot or a photo of these upcoming webinars, or we also have them posted on our website or social media channels where you can find the registration links for these as well. And then if you happen to miss a webinar or you can't make it to one of them, you can find all of our past webinar recordings on our YouTube channel. So it's just at CISWP, and we will be uploading all of the webinars from the work from home series as well as this paramedic series. And I just want to thank everyone again for taking the time to join us today. We hope to see you at the future webinars of this series as our researchers will be discussing their findings in more detail. So thank you all, and I hope you all have a great rest of your day.